Good morning and greetings from Toronto. I'm Michael Fehlings, Professor of Neurosurgery at the University of Toronto, and it's a real pleasure to take part in this Seattle Science Foundation update on innovations in spine. And I'll be providing some reflections on myelopathy and how to optimize treatment approaches. And I realize that this audience is quite experienced with the management of cervical myelopathy, so I'm try to focus on some knowledge gaps, in particular have a focus on the nuances of managing mild degenerative cervical myelopathy. So I don't have any disclosures that are relevant to this talk. Just for transparency, I have spun off a regenerative medicine biotech company called IntelliGex, but I won't be discussing any of that work in this talk. And I just want to acknowledge Rod and Jens, your very dear friends. I wish I were there with you. I think I need to be like, Star Wars character and be able to shoot across, North America in nanoseconds. But in the absence of that, I think we have the hybrid technologies via Zoom. So thank you so much for this invitation. In 2015, we coined the term degenerative cervical myelopathy as an all-encompassing term which would incorporate issues such as cervical spondylotic myelopathy, ossification of the posterior longitudinal ligament, and a variety of other benign, non-neoplastic, non-traumatic pathologies that result in progressive cervical cord compression. And we recognize that the pathophysiology includes static factors resulting in compression and ischemia, dynamic factors resulting from dynamic compression, axial tension, and deformity, as well as biomolecular factors intrinsic to the spinal cord, including inflammation, ischemia, and excitotoxicity. And in truth, much more needs to be learned related to the pathobiology, but this is an initial concept. A number of years ago, my colleagues and I validated the Modified Japanese Orthopedic Association scale, which is illustrated on this slide. And this is now the gold standard in terms of the classification of the severity in DCM. And we look at motor dysfunction in the upper and lower extremities, sensor dysfunction, and sphincter dysfunction. And mild is graded 15 to 17, moderate 12 to 14. And then there's quite a broad range of severe, 0 to 11, which in truth encompasses both a very severe and a moderately severe phenotype. This outcome measure does require perfection because it's not particularly sensitive for milder forms of impairment, which I'm going to get to in a moment. A number of years ago, based on a number of prospective studies, including some of which I led through the AO Spine North American, AO Spine International networks, we issued these guidelines, and these have been very helpful in terms of guiding treatment. So just by way of review, in putting these guidelines together, we conducted systematic reviews of the best available evidence. These are forest plots of the outcomes of surgical treatment for DCM at short-term follow-up up to a year, intermediate long-term follow-up up to about 3 months, and longer-term follow-up of several years. And these diamonds show the mean improvements at 95% confidence intervals. So these are very large improvements that are seen in functional outcomes with surgical treatment for degenerative cervical myelopathy. So based on this, for patients with moderate and severe DCM, a very clear recommendation arose, which is that surgical intervention should be undertaken. But the quandary arises in how best to manage patients with mild DCM. And here there's equipoise between either offering a period of observation and non-operative structured management versus potentially going in initially upfront with surgery. And some of this involves patient and physician preferences and a shared decision-making framework. But the reality is that mild DCM represents a key knowledge gap and an opportunity for innovation. And it's an opportunity to personalize the management of patients with mild DCM. So we need improved clinical prediction models. We need a better understanding of the natural history. We need improved outcome measures. Potentially the use of microstructural MRI as an imaging biomarker can be a valuable adjunct. And we also need to consider genetic and serological biomarkers as a way potentially to try to point out which patients genetically might be at more risk for developing DCM. And we also need a better understanding of the pathophysiology. So let me present a case, and I'll shift the actual presentation in a few different ways to give you a sense of the dilemmas that we face. So here's a 67-year-old woman. She comes into my clinic. She's complaining of mild neck pain, bilateral radicular arm pain, and she has some mild hand weakness. On an examination, I found some intrinsic weakness, a Hoffman sign, slightly broad-based gait, slightly increased tone, and I felt that she had evidence of an early myelopathy, and I graded her MGOA at 15. So just at the borderline between mild and moderate. Okay, very good. So what's the best way then to manage this? Should we be offering upfront surgery? So here are some of the axial imaging studies. They show pretty impressive compression, particularly at the C5-6 level. Here, C6-7, which also shows a moderately severe degree of compression. But let's twist this around. Let's consider some different clinical scenarios. Let's say the patient comes in with minimal neck pain, a cervical stenosis, identical imaging, but absolutely no neurological symptoms or signs. How best to manage? Or let's say that there is neck pain, but now there's a cervical radiculopathy with cervical stenosis. And then the third scenario is the one that she actually presented to me with, which is evidence of an early myelopathy. Okay, so by way of background here, we have a cartoon showing the different pathologies in DCM, and here's an actual image showing one of the classic forms of DCM related to multi-level cervical spondylosis with cord compression. So DCM is the leading cause of spinal cord dysfunction globally, and it's a form of non-traumatic spinal cord injury. There are age-related degenerative changes in the cervical spine. It results in spinal cord compression, and there's ischemia and inflammation. So how do we interpret this image? So here's a sagittal T2-weighted MRI from another patient. We see here that there's increased signal change in the T2-weighted images and extends above and beyond this area of injury. And so clearly there's a lesion, but is this predictive of outcome and should it influence surgery? So how do we get a better handle on this? And here I would argue that multiparametric quantitative MRI is a solution. So we can think about this in different ways. So we can use T2-weighted, T2 star-weighted imaging to assess atrophy and compression. We can look at magnetization transfer ratios to look at demyelination. We can assess axonal injury with diffusion tensor imaging and fractional anisotropy. And a particularly relevant, very easy technique to use that all of you could actually use tomorrow in your clinics is this one. This is looking at the white matter to gray matter ratio of the T2 star weighted imaging. And this is indicative of demyelination and gliosis, and is predictive of patients with mild myelopathy who will go on to deteriorate. Now you can add in Julian Cohen-Adad's spinal cord toolbox, and this is a freely available software package that you or your radiologist can use to help analyze these images. So this is work from our group. This was one of my PhD students, Alan Martin, who's now a neurosurgeon at UC Davis. And Alan was examining a T2 star weighted white matter to gray matter signal intensity ratio. This is the paper from American Journal of Neuroradiology. And we had a cohort of DCM patients, and we found that this metric reflected demyelination, gliosis, and other changes. And in white matter injury, the gray-white contrast is reduced. And so this is indicative of ongoing inflammation, degeneration, and is predictive of patients with mild myelopathy who will go on to deterioration. And so this is really what we're trying to get a handle on. We're trying to see, okay, which of the patients with chronic compression are going to progress through this pathophysiological cascade. And I think that diffusion tensor imaging, as well as this gray matter to white matter T2 star, is an extremely helpful technique. We have wonderful surgical techniques that are available, but we need a better handle on the natural history of cervical myelopathy. And we recommend that about a quarter of patients will deteriorate over about a 4-year observation a period. And this is summarized in this classic article by Matz, Resnick, and others. So again, so here we are with the AO Spine CSRS guidelines and looking at mild myelopathy, and where do we go with this, right? Because it looks like there is kind of equipoise between a careful follow-up with structured rehabilitation versus upfront surgery. And so, how do we start balancing risk and benefit? So we started looking at this and using a variety of novel machine learning, artificial intelligence techniques to analyze large data sets that we have gathered. So this is one of the papers that we were looking at in the mild DCM population. And we had almost 200 patients out of our 757 patient cohort that we assessed. So one of the things that we see here is that although the patients are graded by the surgical team as having mild impairment, the patients themselves feel that they have substantial impairment if you look at the SF-36 physical and mental component domains. And there's a substantial improvement with surgery. So for example, if you look at the SF-36 physical functioning domain, the population norms are at 85.8, and patients with mild DCM rate themselves at 40, so very low. And surgical decompression improves function, disability, and quality of life in patients with mild DCM. So one of the approaches that you can use in the assessment of patients with mild DCM is the SF-36 DCS and MCS scores, or you can ask your patients whether this is having a significant impact on their lives. So what are the outcomes of surgical decompression in a mild DCM? The patients are heterogeneous. The outcomes are a bit heterogeneous. So about half of patients will have a substantial improvement in their neck disability index, and then other patients have a bit less improvement. So what are the predictive factors? So here we used a principal component regression analysis, and this is a type of supervised machine learning, and we clustered the different factors together. So the negative predictors in the mild cohort were older patients, patients with a lot of medical comorbidities, and heavy smokers. And positive predictors, very interestingly, patients with anterior surgery for milder DCM appear to do well, and potentially because it's a bit better at decompressing the nerve roots, and probably because there's less pain associated with this type of surgical intervention. So if we look at this cohort of mild DCM, we can classify this now on the basis of the physical component scores and the neck disability index. And so if there's a substantial impairment on the physical component score of the SF-36 as well as the neck disability index, these are the responders. Then there's an intermediate group, and then there are patients who have minimal impairment. And these are really the patients that you should watch. So let's come back to this patient with minimal neck pain and cervical stenosis, evidence of an early myelopathy. And this is how I managed her. I'm a big fan of the standalone multi-level anterior cervical scectomy infusion, and she had an excellent outcome, completely free of radicular myelopathic symptoms or signs, MDOA of 18 at long-term follow-up. It's important to note that mild DCM does not always have a benign prognosis. And this is a cohort of patients that we followed in Toronto, and over 50% of patients at 2-year follow-up ended up requiring surgery. So the patients require careful follow-up. So I alluded to the impact of genetics, and I want to leave you here with a take-home message around the importance of ApoE4, which has been linked to the development of Alzheimer's disease and is also linked to various other forms of neurological impairment. And the usual allele is ApoE3, and patients with ApoE4 have a greater inflammatory response and are prone to nerve cell injury. And in this cohort of patients, we found that the ApoE4 carriers in blue had an inferior outcome to surgical decompression versus the wild type ApoE3 subtype. So in conclusion, surgery is safe and effective for mild DCM. Mild DCM is a heterogeneous population, and decision-making is a shared process. Pain is a big driver, and it's important to recognize. And the SF-36 is a valuable instrument to consider using in the assessment. So future clinical decision analysis will benefit from new approaches, including machine learning and artificial intelligence approaches to guide decision-making, microstructural MRI, and genetics, for example, ApoE4 assessment. And clearly we need improved outcome measures and improved understanding of pathophysiology. Ultimately, in the future, it's anticipated that neuroprotective and neuroregenerative strategies will also play
my exposure
an
was very
increasing
quick and
role.
dirty.
And on that note, I'd like to close and happy to take questions.
So just to communicate with Michael, he's still not communicado right now. So Ganesh, let's arm you with a microphone. You live in an extremely competitive city, and somebody in a rivaling institution named Dr. Gogavala put down a very nice preference trial in terms of those equivocal kind of CSM disease patients where we did not have a clear answer. Here you see a patient with mild CSM. What are you going to tell that patient? This hyper-competitive Boston environment, 5, 6 spectacular centers, and a easy driving radius. So how do you handle that patient?
So, the first is, you're absolutely right. I'll actually see these patients as in the competitive city as a second or third opinion as to what should the management strategy be here. I think the first is to really ensure that what we're evaluating is indeed myelopathy and not a variant of something else like carpal tunnel, and do a really thorough evaluation and confirm to myself that that is indeed the diagnosis. And the second is to, I find that patients don't do well when you try to scare them into a surgery. And so I don't go down the road of saying that if you don't do something tomorrow, something bad is going to happen. Dr. Fehlings in that systematic review did highlight a couple things that are really key when I counsel patients. The first is to let them know that 90% of patients do get better, especially with following some form of decompressive procedure. But the predictors of getting better are patients who have milder symptoms, and then the second is the length of duration of the symptoms. So I do counsel the patients that while I would not scare them into a surgery right away, I would counsel them to keep an eye on their symptoms, and then I would follow them up in a short period of time if they weren't ready to make a decision.
John, you referred to the ABOS recertification exam, which I also had the pleasure of doing recently. The recertification exams, though, there was a strong preponderance on the study by Gogavala et al. On the CSM studies, and one of the weird side effects of that research was a much higher than anticipated complication rate of anterior neck surgeries. The results of the Gogavala study are kind of in conflict with what Michael Fehlings just right now quoted, where anterior neck surgery seemed to be very good. How do you align anterior versus posterior, and are we overlooking laminoplasties as a very effective treatment in appropriate patients?
Yeah, it's interesting. That paper, that paper also basically said that laminoplasties did the best.
Yeah.
And I tend to kind of agree with that with multi-level disease. I really like laminoplasties. I think the Japanese have been doing it for about half a century now, and they've got a lot of data that says it works pretty good. So I think also that anterior complications are underreported by a great deal. I think a lot of people have long-lasting dysphagia from multi-level anterior surgeries. And a lot of times with CSM, you're dealing with 3, 4, 5 levels. And, a single-level ACDF with minimal retraction, or even 2 levels, or corpectomy, is a pretty well-tolerated procedure in most surgeons' hands. Some guys are better, but there's no question that you've got to dissect a lot more tissue to address with multi-level ACDFs. So anybody that's got neutral to lordosis, I tend to do posteriorly with a laminoplasty nowadays, because I just basically put them in a soft collar and tell them to come back in 6 weeks and move their neck however they want, and they come back just feeling really quite fine. Now, there's a lot of different kinds of people. Like an older person with arthritic changes is not the same as a 50-year-old with congenital cervical stenosis. Those people do wonderfully with a laminoplasty. Maybe less so with an older patient who's already got intrinsic arthritis. And so I just think for those reasons that I think a lot of anterior multi-level complications are underreported. And I think that for multi-level disease, you ought to lean toward either a posterior decompression fusion, which is still a good procedure, quite honestly. I have a lot of people we do that on that do great for many, many years, or laminoplasty.
Sean, in Far East Asia, again, I was so impressed with the prevalence of laminoplasties being kind of almost the first order of business in Korea and Japan. Why did that not take a greater prevalence here in North America? What are your thoughts?
I think there's several reasons, and one, I think laminoplasty was started because of in an attempt to treat OPLL. As you know, that OPLL is a more prevalent problem in Eastern Asian country, so that's one of the reasons. Probably, there wasn't enough OPLL patients for you to make sense of to master skill. Laminoplasty is not easy to do, and I still feel more comfortable doing ACDF than laminoplasty. I think that's one reason. The other reason is economics, and
Cost.
you get paid a lot more by fusing anterior cervical fusion than laminoplasty. Those are two reasons I can think of.
Laminoplasty is such a beautifully elegant procedure when you do it right. It's just feels so good, you know, and when you get good at them, it's a really worthwhile procedure, but it is low reimbursing.
I agree also with these very honest statements. So for me, that's still my favorite go-to procedure, I have to say. And again, I don't worry too much about the payment aspect, but it's a factor economically. And again, in this country, it's undertaught. But after the Gogawala studies, I think we should revisit that. I hear that the lab is ready. JJ?